You walk into your patient's room. It's maybe 2 in the morning, and they are suddenly just incredibly restless.
Yeah, just tossing and turning in the bed.
Right, they're pulling at their hospital gown, maybe even picking at their IV lines. And the immediate instinct for a lot of people is to think, oh, they're just confused.
Or they assume it's just, standard hospital delirium that needs a little redirection.
Exactly. But there is a very real chance that their brain is quietly, desperately starving for oxygen.
And that sudden agitation, it's one of the most terrifying but easily misunderstood moments at the bedside.
Oh, absolutely.
It is a massive physiological alarm bell that something has gone fundamentally wrong with their respiratory system long before you ever hear them gasp for air.
Welcome to an episode of the Super Nurse Podcast, created by the incredible Brooke Wallace. If you're just joining us, Brooke is a 20-year ICU nurse, an organ transplant coordinator, a clinical instructor,
And a published author. But we want to make it crystal clear right up front, we are not Brooke Wallace.
We are definitely not. We're using her personal bedside knowledge, her meticulous clinical notes, and her signature teaching style to help you, the nursing student, or the brand new nurse.
Right. The goal is to help you bridge that massive gap between textbook theory and real, life-saving patient care.
We are taking the high-yield concepts that you have to know to pass the NCLEX and translating them into what they actually look like when you are standing in front of a real, breathing, highly unpredictable patient.
And real quick, before we jump in, we warmly invite you to subscribe and watch the video version of this episode on YouTube.
Yes. The link is right down there in the description, and our channel is called Super Nurse AI. You are really going to want to see the video for this one.
For sure. So today, our focus is pneumonia. We are looking at exactly what the exams are testing, but more importantly, why these concepts matter so much in the real world of bedside nursing.
Because, before we can successfully treat a respiratory crisis, we have to understand the actual mechanics of what we are fighting.
Right. And clinical experience shows that pneumonia is not just a bad cough or like a little bit of chest congestion. It is a severe infection causing intense, damaging inflammation deep inside the lungs.
Specifically, this battle is happening all the way down in the alveoli. Those are the tiny, delicate little balloon-like air sacs where gas exchange actually happens.
Yeah, to understand the pathology, you really have to visualize what is happening at the cellular level. When bacteria or viruses invade the lower respiratory tract, the body mounts this massive immune response.
Which causes widespread inflammation.
Exactly. The capillaries surrounding the alveoli, they dilate and become highly permeable.
So they basically become leaky.
Right, they get super leaky. So instead of being full of air, the alveoli physically fill up with fluid, mucus, and all the infectious debris that's leaking out of those capillaries.
Which is so wild to think about. I always think of the lungs as a sponge. Like a normal, healthy lung is like a dry, fluffy sponge that effortlessly soaks up air as it expands.
That's a great way to picture it.
But with pneumonia, that sponge is completely waterlogged. It's full of this thick, sticky, infected liquid. So because it's already full of fluid, it physically cannot take in anything new.
And the mechanical consequence of that waterlogged sponge is severe. This is the literal definition of impaired gas exchange.
Right.
The alveoli are surrounded by that tiny, intricate web of capillaries. Normally, oxygen diffuses across that incredibly thin membrane into the blood, and carbon dioxide diffuses out to be exhaled.
But with pneumonia, oxygen simply cannot penetrate that heavy, thick barrier of fluid.
It just can't, which means oxygen can't get into the bloodstream and carbon dioxide can't get out.
So the CO2 just gets trapped in the blood,
Mm.
and it combines with water to form carbonic acid, which pushes the patient straight into respiratory acidosis.
Yep. And simultaneously, they are pushed into a dangerous state of hypoxia because the tissues just aren't getting the oxygen they need to survive. The alveoli are basically suffocating under a blanket of inflammatory debris.
Wow. Which brings us right back to that 2 a.m. scenario. If the patient is suffocating at a cellular level, I would expect the very first sign to be respiratory. Gasping, clutching the chest, maybe turning blue.
Which makes sense logically.
Right. So what does this actually look like when you first walk into the room? What's the very first clue a newer nurse might miss?
Well, the earliest signs of hypoxia are actually neurological. The brain is the body's canary in the coal mine.
Oh, okay.
It consumes a massive amount of the body's oxygen, making it exquisitely sensitive to even tiny drops in oxygen tension. When oxygen levels start to dip, long before the patient's lips turn cyanotic or they start visibly panting, the brain hits the panic button.
It triggers a massive sympathetic nervous system response.
Exactly. It dumps epinephrine and norepinephrine into the system. The brain realizes it is starving, so it induces this intense state of fight or flight.
So that thrashing, the pulling at lines, the sudden combativeness in a previously calm patient.
Yes, that is the brain screaming for oxygen to survive. Newer nurses often mistake that agitation for anxiety, or they assume the patient is just sundowning.
Which happens all the time.
All the time, and they might even try to medicate the patient to calm them down.
Oh, man, which is the absolute worst thing you could do because sedating them would just depress their respiratory drive even further.
Exactly. You'd be making the problem so much worse.
So once the brain sends that early warning sign of restlessness, the nurse has to pivot, right? You have to look for the classic physical respiratory signs.
Right. We transition from noting the neurological clues to investigating the physiological ones. You will often see a fever, typically over 100.4 degrees Fahrenheit, accompanied by severe chills.
Because the immune system is raising the core temperature.
Yeah, to create an inhospitable environment for the invading bacteria. You'll also assess for dyspnea, observing their work of breathing. Like, are they using accessory muscles? Are they breathing rapidly to try and compensate for the lack of oxygen?
And then there is the sputum. NCLEX questions love to use the word purulent. But translating that to bedside reality, we are talking about thick, yellow, green, or even rusty-colored sputum. I mean, you are dealing with some seriously nasty lung butter.
Bedside nurses see a lot of lung butter, that's for sure, but that rusty color, that's a very specific clinical cue.
Wait, really?
Yeah. It is not actually rust, obviously. It happens because red blood cells and white blood cells get caught up in the severe inflammatory fight inside the lungs.
Oh, wow.
The capillary beds leak red blood cells into the alveoli, and as those cells break down and mix with the macrophages and mucus, it creates that distinct brownish-red, rusty appearance.
So it's basically the microscopic casualties of the immune system's war being coughed up into a tissue.
That's a morbid but very accurate way to put it.
So we've looked at the sputum, we've checked the temperature, and we've noted the increased work of breathing. When we actually grab our stethoscope and listen to a pneumonia patient's lungs, we are primarily listening for crackles and rhonchi, right?
Yes. And the physics of those sounds tell you exactly what is happening inside the chest cavity. Fine crackles, they sound kind of like hair rubbing together right next to your ear.
Like a little crinkling sound.
Exactly. That is the sound of sticky, collapsed alveoli forcefully popping open during inspiration.
Okay, and what about coarse crackles or rhonchi?
Those are much louder, lower-pitched rumbling sounds. That is the acoustic result of air desperately trying to bubble and force its way through that heavy fluid and thick mucus in the larger airways.
Oh, so it is literally the sound of air colliding with liquid.
Yes.
Like blowing bubbles through a very thick milkshake.
That is exactly what it is.
Aside from the sounds, there are worsening signs we have to monitor for. A major red flag is pleuritic chest pain, right? This is a sharp stabbing pain that happens right upon inspiration.
Right, because the lung tissue is so inflamed.
The patient takes a deep breath in, they wince, and their breathing becomes very shallow because it feels like expanding their lungs against broken glass.
Which leads to a vicious cycle. They're in pain, so they take shallower breaths, which means they aren't fully expanding their lungs, which only worsens the pneumonia and the impaired gas exchange.
Yeah.
And through your stethoscope, alongside those crackles, you might hear a pleural friction rub.
I would imagine that is caused by the infection spreading outward, like to the lining of the lungs.
It is. The pleural layers, the membranes surrounding the lungs and lining the chest cavity, have become intensely inflamed.
And normally, those are pretty slick, right?
Yeah. Normally, a tiny amount of cereorous fluid keeps those layers perfectly lubricated so they glide past each other silently when the lungs expand. But inflammation dries that out and makes the tissues rough.
So instead of gliding smoothly, these inflamed tissues are just grinding against each other. It sounds like rough pebbles or heavy sandpaper rubbing together with every single breath.
Precisely. So we have identified the cues of infection. We know it's pneumonia. Now we have to actually treat it. But we have to follow a strict order of operations to keep the patients safe.
Oh, this is the mug shot rule.
Yes. There is a classic prioritization rule regarding diagnostics and medications. You must always obtain a sputum culture before initiating broad-spectrum IV antibiotic.
Wait. If my patient is severely hypoxic and restless, and their brain is literally starving for oxygen, why on earth are we holding off on life-saving medications?
It's a fair question.
My instinct would be to flood their system with broad-spectrum antibiotics instantly. to stop the infection in its tracks, rather than waiting around on respiratory therapy or the lab to get a sample.
It is a highly intuitive reaction, and it is exactly why this trips up so many nursing students on exams. But the mechanism behind the rule is crucial. If you give the antibiotics first, even just one single dose, that medication enters the bloodstream and starts indiscriminately killing bacteria in the lungs.
Which is the goal.
Yes, but if the antibiotic starts killing bacteria before we secure a sample of that sputum and send it to the lab, it alters the bacterial load in the sample.
Oh, I see.
The medication masks the specific organism causing the infection, so the culture will come back inconclusive, or it might grow the wrong bacteria entirely. We need to identify the exact microscopic bug so the healthcare provider can transition the patient from a broad-spectrum guessing game to the exact right targeted drug to eradicate it completely.
Okay, so this is why I call it the mugshot rule. It's like taking a mugshot of a suspect.
Yeah.
You have to snap the mugshot, the culture, before you throw them into a dark jail cell.
Exactly.
If you lock them away in the dark first with broad antibiotics, you'll never be able to identify exactly who you captured or what their specific record is. You snap the mugshot so you know exactly who you were dealing with, and then you can throw the book at them with the correct targeted therapy.
I love that. Snap the mugshot first, then start the IV. And once you've done that, you monitor the patient's objective data to see if the treatment is actually working over the next few days. You track the white blood cell count, or WBC.
Because as the antibiotics successfully clear the invading bacteria, the body's immune system realizes the war is ending. It stops mass-producing neutrophils to fight the infection.
Right.
You will see that elevated white blood cell count steadily drop back down into the normal range.
Yeah.
That is your hard, objective data proving the infection is truly clearing.
But the reality of bedside nursing is that while we wait for the lab to process the culture and while we wait for those IV antibiotics to finally kick in and lower the white blood cell count, the patient is still sitting there in the bed, essentially drowning in their own secretions.
Yeah, you can't just leave them like that.
Exactly. The nurse has to take independent physical action to mobilize that fluid.
And this is where bedside nursing interventions really shine. Positioning is the most immediate tool we have, and it costs absolutely nothing. You place the pneumonia patient in a high Fowler's position, sitting them straight up in bed at like a 60 to 90 degree angle.
Right.
Gravity must be playing a huge role here because lying flat would just push the stomach against the lungs.
That's exactly the physiology behind it. When a patient lies flat on their back, their heavy abdominal organs press upward against the diaphragm, physically restricting its downward movement.
And it has to move down to pull air in.
Yes. The diaphragm needs to drop down to create negative pressure in the chest cavity. By sitting them straight up in high Fowlers, gravity drops those abdominal organs down and away from the diaphragm. This maximizes the physical space in the chest cavity for lung expansion, making it significantly easier to breathe and promoting far better oxygenation.
So you are basically using the weight of their own internal organs to help them breathe. That's amazing.
It's simple, but so effective.
Next on the pulmonary hygiene list is fluid intake. The evidence tells us to encourage 2 to 3 liters of oral fluids per day. But hold on, considering we started this entire discussion by comparing the patient's lungs to a waterlogged sponge, giving a drowning patient more fluid seems completely counterintuitive.
It does seem contradictory at first glance, but we have to remember the anatomical separation between the respiratory tract and the digestive tract. When we encourage oral fluids, that water goes into the stomach, gets absorbed into the bloodstream, and hydrates the body systemically.
Oh, right. So we aren't pouring water into their lungs. We are hydrating the body, which then thins out the secretions from the inside out.
Right. When the patient is dehydrated, the mucus inside the lungs becomes thick, sticky, and glue-like. It adheres to the airway walls, and no matter how hard the patient coughs, they simply cannot generate enough force to expel it.
It's just too stuck.
Exactly. By aggressively hydrating the patient systemically, it turns that nasty, viscous lung butter into a much thinner, looser liquid. The viscosity decreases dramatically, allowing the patient to actually cough it up and clear their airway.
That makes perfect sense. There was one massive clinical caveat here that exams love to test on, though, right?
Yeah.
You only push those fluids if the patient does not have a strict fluid restriction.
Yes, crucial point.
If your pneumonia patient also has heart failure or severe kidney disease, giving them 3 liters of fluid will overwhelm their cardiovascular system and absolutely send them into a dangerous state of fluid overload. A super nurse always checks the chart for heart failure or renal failure first.
Absolutely. So once the mucus is thinned out with hydration, assuming it's safe to do so, we use pulmonary hygiene tactics to get it out. We are coaching the patient to use an incentive spirometer. We are doing the classic turn, cough, and deep breathe routines. And we might even coordinate with respiratory therapy for chest physiotherapy.
To physically percuss and vibrate the chest wall to knock the mucus loose.
Exactly. And this is incredibly vital for our post-operative patients. When a patient goes under general anesthesia, their breathing becomes very slow and shallow.
They aren't taking those deep, sighing breaths we take naturally throughout the day.
Right, which makes post-op patients highly susceptible to atelectasis, which is the physical collapse of the alveoli.
And if those alveoli collapse and just stay closed, bacteria sets up camp in that dark, warm, stagnant space, and suddenly you have a secondary post-op pneumonia.
It happens so fast. Early ambulation and the incentive spirometer are critical because they force those lazy, sleepy air sacs to stretch back open.
You know, newer nurses often see patients blowing into the spirometer like it's a party horn.
Oh, all the time.
But it's an inspiratory tool.
Yeah.
You have to instruct them to seal their lips around it and suck in slowly and deeply, like pulling a very thick milkshake through a straw.
That slow, sustained negative pressure is what pops those collapsed alveoli back open.
Right. But, you know, even with excellent pulmonary hygiene, a pneumonia patient can rapidly decompensate. A sharp bedside nurse needs to understand the physiological mechanisms behind the deadly complications before they escalate.
For sure. Let's examine the big three. Complication number 1 is a pleural effusion. This happens when the inflammation becomes so severe that the fluid doesn't just stay inside the lung tissue, but it leaks out of the visceral pleura and fills the pleural space.
So the actual cavity between the lung itself and the chest wall.
Yes. The mechanism here is driven by that increased capillary permeability we discussed earlier. The fluid leaks into a closed space. And because fluid cannot be compressed as it builds up in the pleural cavity, it physically squishes and collapses the lung tissue from the outside in.
And bedside nurses can actually spot this during their assessment. When you percuss or tap on the chest wall over a pleural effusion, you will hear a dull, flat resonance instead of the normal hollow sound of an air-filled lung.
Exactly.
And their breath sounds will be significantly diminished or completely absent in that specific area because the lung underneath is being compressed and no air is moving through it.
Right. Complication number 2 is ARDS, or acute respiratory distress syndrome. This is a massive escalation.
Yeah, that's a scary one.
The localized lung infection triggers a systemic inflammatory response. This widespread inflammation damages the alveolar capillary membrane entirely. Protein-rich fluid floods the alveoli, washing out the surfactant.
And surfactant is the natural lubricant that keeps the alveoli from sticking together, right?
Yes. Without surfactant, the alveoli collapse entirely. The lungs become incredibly stiff, hard, and non-compliant. Imagine trying to inflate a thick, rigid leather balloon instead of a soft rubber one.
Oh, wow.
The work of breathing becomes impossibly high.
And the hallmark sign of ARDS that they love to test on is refractory hypoxemia. That means the patient's oxygen saturation stays dangerously low no matter how much supplemental oxygen you give them.
Yeah, it's terrifying.
You can crank the oxygen on the wall up to 100%, but because the lungs are so incredibly stiff and the alveoli are completely flooded and collapsed, the oxygen simply cannot cross into the blood.
Which brings us to the third and often most fatal complication, septic shock. This occurs when the localized lung infection completely breaches the pulmonary barrier. The bacteria escape the lungs and enter the systemic bloodstream.
And when that infection enters the blood, the immune system panics, right? It releases a massive flood of inflammatory chemicals, like cytokines, to fight the widespread infection.
Right.
But those chemicals have a devastating side effect on the cardiovascular system. They cause massive systemic vasodilation.
Yeah. Vasodilation is the relaxing and widening of the smooth muscle inside the blood vessels. To visualize this, imagine your cardiovascular system is a standard garden hose with a steady, pressurized stream of water flowing through it.
Okay.
If you suddenly swap that standard garden hose for a massive, wide fire hose, but you keep the exact same amount of water flowing through it, the pressure instantly drops to near zero.
The water just lazily pools at the bottom of the hose.
Exactly.
That is exactly what happens to the patient's blood pressure. The blood vessels dilate so widely that the pressure bottoms out. At the bedside, you are watching for a sudden, dramatic drop in blood pressure, a systolic less than 90, or a mean arterial pressure, a MAP, less than 65.
And when the MAP drops below 65, the pressure is no longer high enough to push blood into the vital organs. The organs stop being perfused.
Which is why their urine output will suddenly drop to practically nothing. The kidneys are highly sensitive to blood pressure changes. If the pressure isn't high enough to push blood through the renal filters, they just stop making urine.
Yep, they shut down.
A dropping urine output, usually less than 30 milliliters per hour, tells you that the kidneys are starving for blood. It is a terrifying cascade of multi-organ failure, all triggered by that initial lung infection.
This is why recognizing the early cues is the difference between a patient recovering or crashing into the ICU.
It really is. So let's summarize the ultimate bedside lessons for pneumonia. Always monitor the airway. Watch like a hawk for that early neurological restlessness before the respiratory signs even show up.
Take the mugshot.
Yes. Take the mugshot by securing the sputum culture before you start the broad-spectrum IV antibiotics. Check for a history of heart failure, and if they are clear, thin out the mucus with oral fluids.
Sit them straight up in high Fowlers to let gravity drop the diaphragm.
Right. And closely monitor for the physiological shifts that signal pleural effusion, ARDS, or septic shock.
You know, by learning this, you are learning how to think critically and recognize physiological patterns. You aren't just memorizing a textbook checklist of symptoms.
Right. You are understanding the mechanics of why the lung is failing at the cellular level and how your specific nursing interventions physically reverse that failure. That clinical judgment is the core of bedside nursing.
It really is.
Before we go, I want to leave you with a provocative final thought pulled straight from Brooks' notes. We know from practice that the elderly population, patients over 65, are at the absolute highest risk for pneumonia. Their immune systems are weaker, and their cough reflex just isn't as strong.
They are definitely the most vulnerable demographic we treat.
So consider this. How often do healthcare workers chalk up an older patient's sudden confusion or a new bout of agitation in the middle of the night to simply dementia or sundowning?
It is an incredibly easy assumption to make, especially when you are managing a heavy patient load.
It happens constantly. We see a confused elderly patient and assume it's just a cognitive baseline issue. But what if, in reality, their brain is literally starving for oxygen because of a silent brewing lung infection?
Right.
What if that agitation is the canary in the coal mine for pneumonia? The bedside lesson here is always check the O2 saturation. Never assume a sudden change in agitation or mental status is just behavioral. Look for the physiological root cause.
I love that. That perspective forces you to look past the surface, question your assumptions, and trust your physiological training over an easy label.
Thank you so much for joining us for this session of the Super Nurse Podcast. Remember to subscribe and watch the video version of this conversation on YouTube. Just search for Super Nurse AI, and the link is right down in the description.
Keep asking those deep physiological questions and keep building that pattern recognition. It will serve you and your patients well.
Absolutely. When you walk into a patient's room at 2 in the morning and find them thrashing and confused, you will know exactly what mechanisms are at play and exactly what to look for. You're becoming the super nurse you were born to be. See you next time.